Good afternoon, good morning to all of you, and welcome to the April edition of Wednesday 4 REMS and More. And we're very pleased to have you join us. Today's topic is health literacy and pharmaceutical risk management. Before I move further into describing that topic and introducing our speaker for today, what I'd like to do is just back up and give a little bit of perspective on the relevance of this as a topic. What's clear is that we've from a number of different perspectives in recent publications, is we've moved into a new era of what are the concerns and objectives related to the implementation of risk management programs, whether they're REMS in the United States or RMPs in EU and beyond. Certain documents recently, like the OIG document issued in February, identifying that FDA does not have the data to determine whether REMS genuinely improve drug safety or not, or patient safety, point out that there is a gap between the activity and the outcome. Likewise, due for 5 reauthorization goals in the United States that set new goals for FDA for the coming due for reauthorization period, make clear that many of those priorities are dealing with making sure that the outcomes of the efforts that are being implemented for REMS are actually improving patient safety. And likewise, the efforts of many pharmaceutical companies are looking towards how to go beyond simply perfunctorily doing the activity. And I'm not suggesting any company was in fact doing that, but how to move beyond an activity basis of risk management and instead move towards doing things that are actually effective. And so as we think about where the points of high leverage are with that across the care process of how to move towards more effective risk minimization, certainly one of the areas that is most important is the area of communication with patients and making sure that what is communicated to them is actually understood and can be acted upon. And so in the spirit of that, we wanted to return to a topic of health literacy in today's webinar. This is a topic actually that in October of 2011, Meredith Smith from Abbott, then Abbott, now AbbVie, made an excellent presentation titled Reducing Medical Errors, the Science Behind Patient Medical Implementation. And in that, she talked extensively about health literacy as well, and in fact, spoke related to a specific pilot study that was done to use health literacy tools to optimize a specific communication tool, and then to a pilot test to determine whether it actually made a difference. So I refer you to that as well to support this whole topic. But today is a bit of a more holistic and global approach to looking at health literacy. And so with that, I'd like to introduce our speaker for today. I'm Jeff Fetterman. I'll be your moderator for today's discussion. And our speaker today is Chris Srinivasan. And Chris is the Clinical Consulting Director here at Paragon Rx. He's a physician and an engineer by training with experience working in many different types of healthcare systems. And Chris brings a clinical innovation and analytics both to the practice of medicine and healthcare. So it's an interesting blend of disciplines that I think you will find brought to today's presentation. In today's session, as I mentioned, it's a bit of an overview and holistic look at health literacy. And so it'll start by defining health literacy in relationship to risk management, ways to measure and analyze health literacy levels, what are the economic effects of health literacy and the link to patient outcomes, the outcome of some literature review and some case studies related to the topic, and then finally, what are some potential future efforts that could be conducted to close the current gap. So I hope you find it instructive. Before I move on to the actual presentation, I'd like to review a little bit about how you can participate. And so as in every month's webinar, we invite you to submit your questions and ideas and even comments that you may have along the way. We'll gather them during the course of the presentation and then provide it in a facilitated question and answer session at the end of this webinar. And so the way for you to submit your questions is in the lower left-hand corner of your screen. There is a section for a chat function, and you can submit your questions to leaders and assistants throughout the entire webinar session. I really encourage you to do so, please. And with that, I'll now turn it over to Chris Srinivasan. Chris.
Thanks, Jeff, for the introduction and having me present today's forums on health literacy and pharmaceutical risk management. My goal for today's discussion is to provide some qualitative background into what is health literacy, how is it measured, and its impact on everyone as a society currently, and also finally how it directly pertains to risk management in the pharmaceutical industry. So in 2003, the Institute of Medicine released a report called A Prescription to End Confusion, and its focus revolved around the importance of health literacy and the steps needed to ensure proper understanding of prescription medications. The report enlisted some expert opinions to develop a general definition which is universally used today as a baseline for health literacy, and the definition was the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. There's a lot of key words in this definition that we're going to be touching upon today and as we go through. One of the key concepts that many do not consider when thinking about health literacy is that it goes beyond the individual patient because it depends on the skills, preferences, and expectations of healthcare providers as well, and also having been provided adequate medical information. So today in the pharmaceutical industry as a whole, there's an identified large void of how many patients truly understand safe use messages that are being obtained, and sometimes how they can be processed. Efforts are being made with REMS assessments and more robust risk minimization plans. But there's actually a great deal of opportunity to be had in this space and a lot of low-hanging fruit, which we'll be talking about as we go forward in this presentation. So here you can see is the current situation outlined pretty briefly. The data is globally recognized from the IOM report, and it's critical to keep in mind that there's a perception versus reality issue, and as we discuss them, keep in mind that many things are perceived when it comes to health literacy, and there's a true reality behind it. So in this, nearly half Americans, and half of all adult Americans, roughly 90 million people, have difficulty understanding and acting upon health information. Now, when I talked about perception versus reality, there's a majority of these folks, of these 90 million adults, that are actually native-born American English speakers. So the perception generally is that we've got a high immigrant population, and because we're kind of a melting pot of a society, that our low literacy rates and health literacy rates are due to that kind of a population. But when the actual reality of the situation is that the majority are actually native-born English American-speaking folks. And also amongst those folks, they're actually of the older generations, and that is something that's been very intriguing to many people doing research in the industry today. So as we continue our discussions, we'll discuss the issue more in depth and show us how it relates to our overall country's economic impact as we move forward. So now you may be wondering how we got to the conclusion of the 90 million adults and how they were depicted as having either low literacy or basic literacy or even below literacy rates going forward. So let's discuss how health literacy is measured and analyzed first, and then we'll move forward as to the current situation as we go up. The National Assessment of Adult Literacy was the first national measure of literacy. It provides a systematic feedback to the education system and to the healthcare system about how literate American adults are. It also provides feedback demonstrated to the level of information conveyed by these systems, and is not a good match with the abilities of most adults. The NAL actually also identified substantial disparities associated with race and ethnicity, age, and also insurance status. While the NAL provided an overall assessment of the level of literacy of American adults, various research measures have been used to establish the relationships among limited health literacy, healthcare, and health outcomes, as well as the impact of interventions on individuals with limited health literacy. In the clinical setting, clinicians and healthcare providers commonly overestimate the health literacy of their patients. This is very common, and like I said before, the perception and reality is always an issue, where a physician or a healthcare provider determines that that they perceive a patient to have a higher level of health literacy when they actually do not have that level, and they speak at a different level, so the understanding is generally not there. Assessing the health literacy of a sample of patients can provide a healthcare provider with information about his or her patient's overall average reading level, which then can be used as a guide in the selection and development of patient education materials. However, there's a concern about universal testing. So some argue that such testing will alienate and stigmatize patients with limited health literacy. Others also will take the position that healthcare professionals must be aware of limitations in a patient's ability to read or understand instructions, so that care can be tailored for each patient. Some even question the burden that additional testing, such as health literacy testing, may cause on the overall healthcare system. But the bottom line is that the benefit-risk analysis of this situation will clearly show that the time taken to ensure proper obtaining, processing, and understanding of health information and prescription materials will result in overall better patient outcomes. This shows that the effective tools and interventions must be accessible to HCPs or healthcare providers, and that they need to be presented with facts supporting why using a given tool to help with health literacy and how to use them efficiently is going to help them in their overall daily practice and eventually improve their overall patient care. Let's take a quick look at a few tools that are currently being used. So, as you see here, there's a few lists of tools here. One being a Lexile analysis, another one being a suitability assessment of materials. A third type of tool is a comprehension test, which we'll talk about all of these in more detail. Another tool is a wide range achievement test. And these last two are actually very important, which we'll spend some time discussing. One being the rapid estimate of adult literacy in medicine, or REALM. And the last tool we'll discuss is called the Test of Functional Health Literacy in Adults, or TOFLA. A Lexile measure is defined as a numeric representation of an individual's reading ability, or a text readability / difficulty. There are two types of Lexile measures. One is a Lexile reader measures, and the other one are Lexile text measures. A Lexile reader measure typically is obtained when an individual completes a reading comprehension test. Once a field study has been performed to link the Lexile framework with the test, the individual's reading score can be reported as a Lexile measure. So this tool will actually be used in one of our case studies that we'll be discussing in the future, so just keep this concept in mind. The next type of tool that we use is called the Suitability Assessment of Materials, or SAM. The SAM offers a systematic method to objectively assess the suitability of health information materials for a particular audience in a short amount of time, generally around 2 to 4 minutes at most. SAM guides you to rate materials on factors that affect readability and comprehension. So readability can be defined as the relative difficulty of decoding the words, and comprehension can be defined as the relative difficulty of understanding the meaning of those words. SAM rates materials in 6 given areas, one being content, another being literacy demand, graphics, layout and type, learning stimulation and motivation, and cultural appropriateness. The actual score that comes out, it takes in all six areas into consideration and performs a full assessment of the patient's actual comprehensibility and readability of the material. Next, we're going to talk about the comprehension test, which is very basic. It's one of those things, excuse me one second. So the comprehension test is basically just that. It determines a level of understanding of the patient, and it can be written, it can be oral, and there's many varieties and forms of that. We're not going to talk much about the wide range achievement test, simply because it hasn't been used too often in the recent times. I want to talk more about the REALM and TOEFL tests. TOEFL, which is also called the Test of Functional Health Literacy in Adults, measures the functional literacy level of patients using real-to-life health materials. These materials include patient education information, prescription bottle labels, registration forms, and instructions for diagnostic testing. The TOEFL assesses two main constructs, numeracy and reading comprehension. It has a total of 67 items. The numeracy scale, used to measure the ability to read and understand numbers, includes 17 items. The reading comprehension scale, used to measure the patient's ability to read and understand healthcare-related passages, contains 50 items. The reading comprehension scale utilizes the closed procedure, a technique that presents the patient with reading passages that are missing every fifth to seventh word. The patient must then select the appropriate missing words from a list of 4 possible different answers. Only one choice is correct with regard to grammar or the context of the sentence. So it's a pretty comprehensive test, and we're going to talk about briefly here is the TOEFL and the Rapid Estimate of Adult Literacy in Medicine. They're both important tools that researchers have used to conduct studies that have shaped the field of health literacy. For example, researchers have found that those with lower health literacy have poorer health care and health outcomes. There was a study done by Baker and some of his colleagues in 2007 that used the TOEFL to determine that inadequate health literacy independently predicts all-cause mortality and cardiovascular death among elderly persons, and that health literacy is a more powerful variable than the education itself. The TOEFL and Rapid Estimate, or the REALM test, have conducted many more studies based on this kind of a basis. So moving forward, as in any tool, you're going to have some limitations, and one of the major limitations are with the health literacy tools is that there's non-standardized methods of determining the actual literacy level amongst patients. When you're dealing with a high variety of patients in a highly variable environment, there's always many, many limitations, and in order to minimize the limitations, standardization is generally one of those constructs of developing a good, solid foundation. So the other limitation of the tools are that most of the tools are unable to differentiate between reading ability, the lack of background knowledge in health, lack of familiarity with language and types of materials, or cultural differences. So some of you might be thinking, well, reading ability we've discussed, the lack of background knowledge in health. Well, how many patients truly have a good background knowledge in health? Which is true, but when you come to literacy levels, you have to have some construct and some foundation. And if you can standardize that foundation, it helps moving forward. Some fundamental questions that need to be answered when assessing the state of art of the health literacy measurement would be such as, how well do current approaches to measurement succeed in differentiating health literacy from any other literacy generally? Another question to be asked and answered, and should be answered, are how well do current measures capture an individual's ability to obtain, process, and understand health information? Another question would be, how are measures sensitive to healthcare and public health improvement efforts? And also, should disparities be included in these measures? That's kind of a concept that many people don't think about, or either health disparities or even economic disparities, and how do those overall provide a construct or foundation for health literacy, and how those tools should be designed to help measure it. So currently, there's no open access comprehensive measure for health literacy, although there should be. Comprehensive measures build a foundation of knowledge that is needed to enable accurate screening and to advance health literacy as a tool to improve health and reduce adverse events in a given patient's treatment process. To build a comprehensive measure of literacy, all the experts in the field can use the construct of tools that we just talked about, and they need to come to a commonly agreed upon health literacy definition. Although the IOM report provided a general definition, there are still many experts in the field who have alternating opinions as to what is health literacy. So in the given time and in the given future, there needs to be a standardization of the basic definition of health literacy, and that needs to be agreed upon to move forward on various projects. So up to this point, we've discussed a basic definition of health literacy, and that still needs to be advanced by more experts in the field. We've discussed a variety of tools that exist to help healthcare providers determine whether their patients understand the treatment protocols being given and how their medications are supposed to be taken. But those tools are still being heavily underutilized due to many limitations that we just briefly discussed. So moving forward, now let's look at the result of all the confusion revolving around health literacy and how it impacts not only the health of patients, but the health of our economy. Medicare is one of the largest payers in the country, and they have an overwhelming majority of patients who are on prescription medications. With 50% of the population, of the U.S. population taking 5 or more meds, there are definitely some low-hanging fruit here to help ensure that they are properly educated and understand the safe use of those medications. So your average patient who's on 2 medications may not need as much attention as those who need 5. But regardless of how many they're taking, there has to be a standard procedure and process to help ensure that their health literacy levels are not a barrier to them understanding any of the materials that are given. Unfortunately, it is found that over half of those patients do not follow a medication regimen, and nearly a third do not even fill a script. Now, there are many speculative reasons as to why those things happen, but the basic construct is many people don't understand the importance of following a regimen or actually filling their script. And many actually, depending on their backgrounds, actually are scared to fill a script because they don't understand the facts behind the medication. So they just choose not to get better using a medication. Also, many would agree that nearly 2/3 of patients not understanding their medication information, and with 40% of those people not being able to read the labels, it would be difficult for them to actually be able to manage their medication profiles and to even safely administer their medications. These statistics are some of many more disturbing figures that show why health literacy is a critical component of medication safe use and overall positive patient outcomes. They are also crucial to the economic viability of our country, and could also be in the crux of helping our government even start to chip away at our national debt. Let's discuss why now with a few figures. With 36% of the adult U.S. population having basic or below basic health literacy levels, they're either not taking their medications properly or they're not taking them at all, which in any case is going to be leading to adverse health outcomes. The cost of this low level of health literacy is estimated to be between $106 to $238 billion annually. That's every year. If we can minimize this annual cost with a few simple standardized methods of practice for healthcare providers to effectively use, and also for patients to definitely be able to understand, we can effectively reduce our national debt by nearly 1 to 2%. Well, that sounds kind of small on the big figure, roughly $17 trillion in debt. That amounts to be a huge number. The lack of doing anything will actually cost anywhere from $1.6 to $3.6 trillion as it stands today. As we discussed earlier, the target market for reducing these numbers are generally white native-born Americans who are an older population, which could be some surprise to many. A commonly discussed action to help control these costs are stable coverage and reliable health access to those that are in need. Also, effectively involving healthcare providers to utilize all tools in an efficient manner to ensure safe use medication for positive patient outcomes is critical to our economy. So now, let's focus more on the impacts of health literacy in the pharmaceutical risk management planning and strategy. There are a few key focal points within the industry where literacy levels are critical to measure and ensure that a patient has proper understanding of safe use. So some of the issues dealing with risk management include existing labeling problems that lead to medication error. It's a highly studied area that we will discuss in a few minutes with one of our case studies. But the crux of the problem is that the labeling is not well understood by patients, and it is one tool that is used for patient education about a given product. So there's definitely a major discrepancy there when you're designing a tool to help with patient education and when studies are showing that it's actually doing just the opposite of that. So next, consumer-directed information is also too complex for the majority of patients, and so proper medication-safe use messaging is not quite being effective. This type of information is ideally used and relied upon by healthcare providers who prescribe a given medication, so if it's not effective, then there's no second line of defense for any patient to obtain, process, or even understand the medication-safe use messages that we as a pharmaceutical industry are trying to convey to our patients. A tool to help identify the points of failure in the care delivery process is something called a failure modes and effects analysis. As you may, for those of you who are highly regarded with the webinar, you've definitely come across some of those concepts. It's a rigorous process that effectively helps mitigate risks because specific and redundant interventions are designed to help prevent failure from ever occurring or allowing for positive patient outcomes. So the bottom line is that not only one tool is needed to help mitigate risks of health literacy and messaging not getting across. There need to be multiple tools and multiple different points in the care process that needs to happen. This process and its interventions are heavily used in the provider-patient relationship to ensure that proper and effective education can occur when the patient is having an understanding with the patient and disease process. Without this kind of a redundant interventional kind of process, patients will definitely miss the concept and miss the overall safe use message that are being given out. So moving on, we'll actually be discussing the issue around current medication guides in one of our next case studies and how researchers believe they are not adequate currently for mitigating the risk of adverse events. Medication guides is another interesting topic aside from labels, since medication guides are considered, according to REMS standards, to be one of the major patient educational tools for medication safe use processes. So we'll talk about that in a few minutes in one of our upcoming case studies. So case study number one, we're going to talk about existing medication labels. First, we're going to look at this medication labeling, which was analyzed by a group of researchers, who hypothesized that patients' comprehension of prescription drug labels is inadequate and may lead to medication error or less effective treatment. Their objective here was to test whether the use of more explicit language to describe dose and frequency of use for prescribed drugs could improve comprehension, especially amongst patients with limited literacy. The methods that they used took 359 adults who were waiting for an appointment in 2 hospital-based primary care clinics and 1 federally qualified clinic center in Louisiana, Illinois, and also New York, all respectively. So what the researchers actually ended up finding were that patients were significantly more likely to understand instructions with explicit time periods. So in other words, if you told a patient to take a drug twice daily, it would be a less effective approach than to tell them you want to take 1 pill in the morning and then 1 pill at night. And they even can go even further and give them a time period of taking them. It's either 9 a.m. and then 2 p.m. or 9 a.m. and then 5 p.m. And also, giving precise times was highly effective according to the trial. So hourly intervals or even specific times. In a multivariate analysis, dosage instructions with specific times or periods were significantly more likely to be understood compared to instructions stating times per day. Low and marginal literacy remained statistically significant independent predictors of misinterpreting instructions. So this shows that an effective communication method when it comes to providing adequate health literacy techniques to patients is to be as specific as possible. So the use of precise and specific wording on prescription drug labeling instructions can significantly improve patient comprehension. However, the study also showed that patients with limited health literacy were more likely to misinterpret instructions despite the use of more explicit language. So there's a catch-22 here. So folks who are up to a given amount of health literacy, they'll actually understand and do better with specific times. But beyond that, they're actually not going to get any better. So what does this actually mean for us? Is that there's no one magical tool that can be used on low literacy patients and enable them to effectively understand their medication safe use process. And so I'm reiterating the previous point that I made. Redundant tools are needed to be built into a system to ensure that the proper messaging is received and, more importantly, understood by the patient. Let's look at a second case study, as I mentioned before, dealing with medication guides. So this case study was previously presented in a webinar, as Jeff had mentioned earlier, by Meredith Smith from currently AbbVie. It was a highly detailed and a very, very important case study. So I thought it'd be great to revisit it because it shows that over time, new tools and research has shown the inadequacy of medication guides. Yet we still utilize them as the main source of patient education. This unilateral thought process needs to change, and it must come from our industry leaders to initiate and follow through with it. So this case study is an overview for those who are unaware or haven't come across this study. It deals with the determination of whether medication guide messaging is appropriately written for all patients. The objective of the study was to investigate whether consumer-directed FDA-approved med guides issued for potentially harmful medications are likely to be useful for patients with limited health literacy. This study actually used two types of analysis tools that we talked about, the Lexile analysis and the SAM, which is the suitability assessment of materials, and was conducted on the 40 currently issued medication guides at the time to evaluate reading difficulty, content, and format. Structured interviews with a health literacy assessment were also conducted among 251 primary care patients at a public clinic in Louisiana to determine if patients directed attention to medication guides and other accompanying patient information materials. So the results are actually showing that the average Lexile score estimated an 11th to 12th grade reading level for the medication guides. None of the 40 medication guides that were used in this study met federal recommendations, which are generally between 6th and 8th grade level. So that's a major gap. And this is not new information. It's been very old. Not old, but it's been done before. And the disturbing portion is that medication guides have had minimal change since the study has come out. And more recently, even as late last year, Dr. Michael Wolf and many of his colleagues have put out another study that was recently done to effectively show essentially the same kind of results, that medication guides are overly complicated for the current reading level of people and patients that are using the medications. So some of the key recommendations from the study are that the reading level of text in medication guides should be reduced. Summaries and highlights should be provided in a more succinct and health literate fashion. And also the scope of information should be more limited. And all these are going to help to increase the likelihood of use, number one, amongst individuals with health literacy, and also, number two, increase the understanding that they have of the content of these tools. In order to get there, consumers, patients, us as a pharmaceutical industry, and also healthcare providers should be involved in the development of medication guides because they are the ones who are directly involved with obtaining, processing, and understanding the content of these tools. If we're able to think of the future initiatives that involve cross-functional teams of clinical, behavioral, and social experts to design effective medication guides, then we can move forward with bridging the gap between low literacy level patients and adverse patient outcomes. So adverse patient outcomes is actually going to be the topic of our final case study here. This case study is a literature review of existing research that addresses the levels of low health literacy and health outcomes. It showed that patients with low literacy were anywhere from 1.5 to 3 times more likely to experience a poorer outcome. And this is significant because if you remember in our earlier conversation about the cost of healthcare and literacy, this would be a direct contributor to all those figures. So the background of the research project was basically looking at over the 90 million adults in the U.S. who have poor literacy levels. They took about 73 articles, research articles currently out on the market, in the public domain, and which met inclusion criteria, and 44 were addressed in this specific report. Patients with low literacy were generally 1.5 to 3 times, as I said before. And so the conclusion we can draw is that low literacy is associated with several adverse health outcomes. Now, why is this all important? Many people are saying, well, okay, adverse health outcomes, it's a common knowledge, but we can always help mitigate that. In the future, as ACOs and more the shift towards outcome-based reimbursements and how the payment system's working, the platform which with patient health outcomes are the standard for healthcare reimbursement, health literacy is going to be a critical point of contact for ensuring good patient outcomes. When a patient is unable to understand or process medication safe use instructions, healthcare providers are at risk because they may not be reimbursed due to the likelihood of an adverse event. Because a patient does not understand their disease process, they do not understand their medication protocol process or their overall treatment process. This in turn, for how it's significant to the pharmaceutical industry and why we should be able to design effective risk mitigation plans and management plans, is that if there is a high risk of adverse events for patients on a given product, healthcare providers are going to be more hesitant to prescribing that given product because they're more likely to have an adverse event with their patient and more likely to eventually on the downside, aside from the adverse event, is to not get reimbursed for treating that patient. So this level of complexity is showing how health literacy tools and design interventions can help ensure good patient outcomes and good economic standing with our country's providers and our overall country's economics. Now, you may be considering at this point in the conversation, well, why haven't these issues and so many low-hanging fruit have been addressed and acted upon? So here are some current barriers to improvements. Lack of meaningful standards or guidance for content and format. Lack of incentives for the industry, multiple documents and redundancy, so that's the variability we're talking about. Also, lack of patient orientation, standardized patient orientation of what is the baseline need for health literate materials and tools. The last three bullets here are all about research, so the limited research about causal relationship between health literacy level and patient health outcomes. There's also limited published information regarding the role of health literacy and medication safe use initiatives. Although in recent times there's been more of a push for it, the funding on the back end for such projects and research has been still limited and still stretched. So that's an area of opportunity for us. And finally, limited engagement of healthcare providers in the practice of safe use medications. So as we look at this list, there's basically three groups. One is to look at standardization of our safe use tools and improvements. Two is to look at the incentivization structure. And three is adequate research for proof of viable interventions and current need. All three current projects can be initiated and by many different organizations and be scaled to such a level with proper support that there will be actionable events from the research rather than more or less stated facts that we have currently. So the last point here, limited engagement of healthcare providers in the practice of safe use of medication, is a big one because engaging your healthcare providers and active involvement with them is critical to ensuring future interventions are designed in a way that's beneficial both to the patient and provider, and also when it's designed by those who are involved in the process directly, they're more likely to be used. So up to this point, we have identified current issues, concerns, and barriers to adoption. In order to successfully move into the implementation of health literacy principles, one proposed thought process that stemmed from how to design an effective medication guide is as follows. Keep it very simple, limit and layer information, avoid distractors, provide context, being explicit, and using a patient schema. These are very 6 basic points that can be a foundation for an effective medication safe use messaging system that can ensure positive patient outcomes in our future. So in summary, medication safe use is a globally significant problem. We can all agree to that. Health literacy is an important contributing factor to this medication safe use. Our research has shown that. But what the key is nothing's really been pushed forward to get there. Interventions targeting health literacy in the medication safe use process need to be multi-layered and standardized. Although the FDA has taken effective steps to get in this direction, there's many, many more steps that need to be taken. So in order to get there, the use of an FMEA, or failure mode effects analysis, to identify areas that need, to identify the areas of need for this intervention is critical. Also, enlisting healthcare providers to design risk management interventions and safe use mechanisms is also a critical component. Finally, testing a design program and continually improving as needed is very, very crucial to the future of continual process improvement of such designed programs. And finally, eliciting a greater response from the pharmaceutical industry for bridging the gaps between medication safe use and health literacy is highly important, because this is where the combination and cross-functional teams of pharmaceutical industry and the clinical environment can come together and provide positive patient outcomes. So in order to bridge gaps as an industry, we must also be actively looking to do some of these next steps, proposing collaborative projects with health literacy experts, also utilizing healthcare providers to design interventions for identified points of failure and designing effective interventions as well. Exploring current REMS and non-REMS tools for health literacy gaps, that would be very useful at this point as a baseline literature study. And also, finally, designing enhanced interventional tools, interventions or tools, to ensure safe use while conforming to appropriate health literacy standards is the basic crux of our whole argument here. And with that, we'll move on to the questioning portion of the webinar, and I'll turn it over to Jeff to explain how it'll work.
Chris, thank you very much for the really in-depth look at health literacy and how it affects health outcomes and, for that matter, economic outcomes as well. So I genuinely appreciate that. What I want to do now is open this up for questions to everyone on the webinar. You can submit your questions. Again, a reminder, you can submit your questions by clicking on the Leaders and Assistants tab in the chat function on the bottom lower left portion of your screen, and we'll collect those questions and pose them to Chris for him to answer. While we're waiting for some of your initial questions, I want to just do a bit of a tangential notice to you here. And so with that, I'd like to introduce what's being called the First Term Summit. I want to make you aware of this. This is being hosted by TERM. I'll tell you what TERM is, Lehigh University's Department of Industrial Systems Engineering and Healthcare Systems Engineering. Before I describe what the program is about, it addresses the same topic that Chris was just describing. So Chris is describing why is there a gap in outcomes, and one of the reasons is related to poor health literacy, and describe the literature behind that. In order to be able to make these correlations, we need to be able to measure and track the effectiveness and the outcomes associated with specific health interventions. In this case, risk minimization interventions and REMS and RMPs. And so that is the topic of this summit. It's called the REMS Assessments and Advanced Concepts Seminar Among Stakeholders. It's being co-hosted by Lehigh University's Healthcare Systems Engineering Department and TERM. As you see, TERM, described here, TERM was established in 2011 as a group of pharmaceutical safety risk management professionals who meet periodically for problem solving and experience sharing. And so this summit is a one-day working seminar which advanced concepts for addressing the outcomes of health interventions will be addressed. And speakers that have been identified or confirmed so far include speakers from the FDA speaking on the topic of future directions for assessing REMS programs, speakers from academia, in this case Dr. Wolf from Northwestern University, who is actually one of the referenced sources in Chris's presentation on health literacy measures of patient burden. Meredith Smith, who we mentioned earlier, will be presenting emerging recommendations for evaluating the effectiveness of risk minimization activities out of existing working groups, whether that's SCIEMS or others, including EMA's GVP Module 16 as it's available. Additional FDA speakers related to the review of REMS assessments, and speakers including Chris, who you heard today, about quantifying REMS program burden on the healthcare system using simulation modeling. Those were the confirmed speakers as of the last public dissemination of this. In addition, we have two additional confirmed speakers at this point, including Russ Glasgow of the NIH, who's involved in health interventions and will have interesting data to share, as well as David Blasser, who is joining from Patients Like Me. And so what the Turn and Lehigh communities have attempted to do is to really gather a cross-disciplinary or cross-stakeholder group of individuals to review this important topic and then to advance a research agenda out of it. So for more information on this, I really encourage you to visit termcommunity.com, and then you can inquire about more information by the Contact Us function there. So with that, I want to turn back now that you've had some time to develop some questions, and I want to return to question and answer. First question is mine, Chris, and that is that you identified that there is a healthcare professional role in health literacy. Health literacy is not just a receiving function, it's also a pitching function. So if there's a healthcare professional role, you as a physician are part of the problem. And so my question is, what can be done to close that gap aside from optimize the communication materials? What can healthcare or risk management professionals in pharma do to help improve the healthcare professional side of the equation?
So I think two things that are critical in that topic, and it's a great question, is that two things that the pharmaceutical industry can do, and leaders in the pharmaceutical industry, is to actively enlist those physicians who become subject matter experts in health literacy and give them an enabling role and almost a portion of where they feel that it's a project that they've started and they've followed through in designing a safe risk mitigation plan at an adequate health literacy level. And secondarily, for healthcare providers to see the need and understand the need for having proper health literacy levels, I think effective research studies to prove to them that it's definitely a major concern and that it'll adversely affect patient outcomes in the future. And this type of a research study or future studies can definitely help enlist physicians into such a process.
Good, thanks for that, Chris. I also thought it was interesting that the note that you made related to the one study that identified that physicians to give explicit time instructions was helpful, although not particularly to low literacy individuals. But those types of teaching tool tips, it seems, would be important in some of these programs that you just described. Another comment here, comment leading to a question, which is, you made comment, Chris, that there was no one magical tool. And in fact, cited this example of giving explicit time directions. And in response to that, you indicated there is a benefit of having redundant tools. And so the question is can you give some more examples and insight about what redundant tools are about? It just seems superficially like it's a waste. What is really behind redundancy?
So redundancy, as you initially stated, is basically designing a system where you have multiple levels and layers of tools that help ensure that a message is being effectively put across to a patient. So in the instance of providing a specific time, that research study helped show that at a given health literacy level, you can achieve an adequate level of understanding based on giving a specific time. But at the same time, at a lower literacy level, you're unable to achieve that same goal. So while tagging on to that same concept, you want to figure out, well, what tools are going to help at the lowest possible literacy level, along with that initial tool, to help ensure that everybody involved in the system gets the message across. So additional tools can help provide, so let's just say for the lowest health literacy person, maybe it's an imaging type thing. They have to show some sort of picturesque type of tool that's going to say, when the sun is up, you're going to take your pill when the sun is up, and then when the sun is down, you're going to take a pill. So it's a very simple, basic tool that can actually be used in addition to a current tool to make sure that people of all levels of health literacy and literacy levels are obtaining the message that's being portrayed.
Thank you for that. One additional question. On this webinar series, the speakers have often pointed to the value of a rigor of methodology, that it's value of risk minimization efforts, that there's a value in using rigorous science-based methods. So you referenced earlier pheromones and effects analysis is one such example, and we've cited others here in other aspects of the webinar or other versions of the webinar. Are we at a point with health literacy where we can now say there's a systematic approach to health literacy that individuals can follow and therefore move towards better outcomes? You defined a pathway at the end of your presentation about a general approach that individuals should take. And my inquiry is that at a level of being systematic where one can fully expect that if you follow the process, you achieve an improvement in health literacy among low health literacy individuals?
Well, there are some systematic processes, as the proposed model that I had shown. That was one that Dr. Wolf and his colleagues actually had come up with while they were doing their medication guide review. There's no universally used systematic process, and the efficacy of those processes hasn't been quite determined yet. So in a short answer, no. In a longer answer, there are tools that are being worked on, and the processes are trying to be developed, and they're still not being universally used.
All right, very good. I believe that's the conclusion of our questions, and we're at the conclusion of our time. So with that, I'd like to close the webinar. The Forums and More webinars occur the second Wednesday of every month. We appreciate you joining us today and hope you found it instructive. The next session is Wednesday, May 8th, and we hope that you and your colleagues will be able to join. Likewise, encourage you not only to seek out information related to the conference we mentioned earlier on the term community, but also to submit any topics that you'd like us to cover to me directly. And likewise, if you have topics or an interest in participating, please likewise make contact with me. My contact information is here. And with that, I'd like to say thank you and good day.